So, our next presenters are Kathleen Bartholomew and John Silver, two of the co founders and leaders of Nurses Transforming Healthcare. NTH is a visionary nonprofit organization with a mission to transform the healthcare system into one focused on wellness and disease prevention. Led by nurses, it advocates for state based regional health systems that are not only affordable and accessible to all, but which also emphasize respect and equality for all care professionals to practice at their full scope of practice. The organization imagines a future where high quality care does not come at the expense of financial well being, and where every individual, regardless of their zip code, can achieve optimal health. So it's my pleasure to hand it over to Kathleen and John and start your clock. Here it goes.
Thank you. Hardest thing for me to do is to have 6 minutes to speak. But I want to begin by echoing what Todd just said. I mean, this organization and this opportunity really gives me hope. And that's why I'm here, because after 20 years as a patient safety expert and a culture expert, the stories and the things I saw, I was hopeless. Nurses Transforming Healthcare, though, is what inspired me and gave me energy again, because I could see a future for healthcare. I could see it working. So the goal of Nurses Transforming Healthcare, founded by John, myself, Leanne Meyer, and Kim Evans, it started about 3 years ago, is to transform healthcare from a business that profits on disease to a service that thrives on wellness. And what do you think that the most frequent comment that we would receive from people is? When we tell them our mission, it's, well, why don't you just solve world hunger while you're at it? I mean, it's just that it's so big, you can't do it. But we're not just a nonprofit. What we are is a social movement, because we want to change healthcare from a business that has a commodity, to a service. And underlying that is research. Donna Bedian said, structure dictates process, which dictates outcomes. And LinkedIn is filled with the outcomes of burnout and suicide and demoralization and poor care and providers being exhausted and patients not getting the care they deserve. But I think people don't understand is there's a lot of good people trying to change the processes. But what we believe is you got to change the structure. If you have a lollipop factory, it's going to make lollipops. And what people, our healthcare system is perfectly designed to produce more sick people every year. It's actually working well. It's working just how it was designed. So in order to impact change, what we realized is we have to create a new structure. And that was the adaptive public utility model. That's the idea that we put forth as a brand new structure. And it's actually not new. Just last year in the New England Journal of Medicine, Catalyst, there was an article about a healthcare utility model that the pharmacy, Civica, did. And what I love the most about this article is that it says that, looking at their tenets, it's about structure, not technology. So how can we put together a structure that keeps Americans well, that really rewards the people who are working in this structure? So one of our pilot projects, we have 3 pillars: to educate, and we've given talks across the U.S. and presented at national conventions; to advocate with congressmen, which we do constantly, to educate people that there's another way that we can do this; and then to support pilot projects. And our pilot project in Spicewood, Texas, I'd like to take a minute to tell you a little bit about that. With great help from the Meyer Family Charitable Foundation and Helping Hands Ministries, we went to a food bank and put a nurse practitioner and a nurse into the food bank. We assessed the social determinants of health and created a score that added urgency, what we've discovered. And then the nurse practitioner created a care plan for 41 of the people who kept coming through this revolving door. The goal was to change it from a revolving door to an escalator that lifted people up. And how you do that is you address their stressors. You address the social determinants of health, which, by the way, I also learned in Texas, I was asked not to say. It's the non-medical drivers of health, to be politically correct. So it was, I think the thing that I love the most is it's so rewarding. It's so rewarding. I mean, trying to get the nurse to even charge for her time, because there's such a sense of satisfaction that fills your soul, which is the reason we went into healthcare. No doctor, nurse, physical therapist, nobody who comes into healthcare to make money on people being sick. And this is the core of our problem. Our values are not aligned with the structure. So how do you change that? I mean, how do you even start? Well, you look at theory. We know that healthcare is a complex adaptive system. It's so big. That's why people say, what are you going to do? How are you going to do that? Well, you look at the research. How do you impact change in a complex adaptive system? You create a hole on. You find one part of that system where you can change it and do everything that Todd's doing and many people on this call are doing and put them in the right place and put them in the same place. So that's why we're having a Flip Your Zip campaign. We're focused on taking one zip code in America. And what if we could take, Prescribe Hope, the Ames model from the University of Washington, the Costa Rica model, Nuka Health in Alaska, and all the wonderful things, mobile clinics, primary care, the essence of which this whole model is what Todd said, the relationship that the provider has with their patients. What if we could reclaim that back again and put that all into one zip code? Denise, could you put the article in the
I
chat?
did. Yes, it's there.
Okay, I have a little bit of more time. So this is called a holon in quantum physics. It's basically something complete and in itself that exists within the whole. And how that impacts changes, people get to see a template. So why can't we go into one zip code in America and demonstrate what healthcare would look like as a service? Because right now it feels like, wow, there's a lot of people doing good things, but if we're going to move it to action, what is the strategy for how to change healthcare, in America? And that's where I'd like to bring in the public utility model and John Silver, because when you look at how you're going to build a structure, John looks at, the 7 goals. You look at the goals. What do you want from this? What kind of a lollipop do you want? I want well people. Okay, well, if I want well people, then I have to build a structure that has these components. And that's why I am so thrilled and honored to work with this team, because it gives me hope. It's the first time I saw, oh my gosh, I can really see this working. I can see a community, where health is a public utility and the social determinants of health are actually the infrastructure. They're the infrastructure for the model. And as we make money keeping people healthier, the community gets to decide because healthcare should be local. Local. Complexity science says that no person, no matter how wise or powerful, can control outcomes from the top. We need to stop and make a local model where the focus is the relationship with the primary care caregiver. And we don't just address the social determinants of health. We actually have the resources and give this zip code the autonomy to decide what do you need in your zip code. John, could you tell everyone how we would do this?
Well, I can try. So I got into healthcare in 74, and after 20 some years, went back, respiratory therapist, nurse, and every other low level job. Went back to get, my bachelor's and master's. By the time I was done with the bachelor's, I knew that really what we were looking at were political problems, both within nursing and within healthcare. So I did my master's with a health policy focus, went up to 2 internships in Washington and worked with a rep here in Florida. In 2000, I decided to do a PhD. Well, I actually had a choice, NP or PhD, and I chose poverty as a PhD. So by then I was really intrigued with what's wrong with healthcare and how do we fix this. I'd already been an ER nurse for 5 years. I heard all the stories. I continued for another 5 years into my doctorate as a practicing ER nurse because it was like this huge research laboratory of people coming in, telling me what their problems were and why they had to see an ER at 8 o'clock at night instead of going to see primaries or specialists. So what I soon realized was that nobody had really put together a cohesive set of goals of what a healthcare system was supposed to do. So I set out kind of attacking this problem, I thought, as a philosopher. And I put everything on the table, including tearing down the whole system and starting over again. So I developed 7 goals that I thought a healthcare system had to have. Some of the things I needed some other expertise in. So when I got to the cost efficiency goal, for example, I stopped for 2 years and went and got an MBA certification from Tulane so I could understand both the micro and macroeconomics to a certain degree. So I got these 7 goals together and I decided, the systems were the problem. It wasn't the individual process. We had HRC grants and university projects and everything all over the country that were showing results, but they weren't really sustainable to any degree. And then you have to factor in some things with the US. We're a federated republic, so there has to be both federal and state contributions, if you want to think of it that, into the health system. And you really have to avoid the socialism trap because that's a political stake in the heart here in the US. So I set out to study health system designs around the world. I went to 3 continents directly, studied the Argentinian system, studied the German system, and went to Great Britain to study the NHS system twice. Then presented at a conference in UCLA where I met people from all around the Pacific Rim. Had many great days of discussions with people from South Korea to Australia, Japan, New Zealand, all of those countries. So I came back and I put every system design I could see around the world. It was a coherent system design on the table. And I went through them one by one to see which ones met all 7 goals. It turned out none of them did. And the good news is our system design, if you want to call it a system, didn't meet any of the 7 goals. So then I had to kind of rethink things. And I thought, philosophically, the problem we have in our country is we've never really decided or had the discussion of whether healthcare is a right or a privilege. We tend to have 2 camps and, one in each pole, but that's about it. And we've never really had an agreement. And of course, if you think of healthcare as a right, then you're pretty much looking at some kind of federal financing system, single payer, something like that, which is going to involve tax money. If you think of healthcare as a privilege, well, then you have to be willing to step over the dead bodies of other Americans. So I thought, what's in the middle? We had to have had a problem in this country before where we weren't willing to call something a right, but it was too important just to be a commodity. So I went back and studied US history, and I found the FDR solution to the electrical problem in the early 20s. Electricity at that time had a lot of the same problems healthcare has now, distribution of resources, a lot of LLCs over these corporations that controlled electrical production, and then a lot of neglect for zones, communities, rural communities, inner city communities that couldn't really afford the rates that they just made up and charged. Sound like healthcare? Yeah. So I looked at the public utility solution that FDR had come up with, and I studied the natural monopoly theory back into England because that's where it came from. So I said, all right, well, and I brought the public utility model forward and put it on the table. And I found out if I changed 2 of the things, if I changed the administrative structure and I give it a sustainable financing model, that this system design takes healthcare, and not just healthcare, innovative healthcare, right down to the street level in every community. It also opens up the door to things like Kathleen was talking about, addressing the social and economic determinants of health. Well, at least those a healthcare system can design. And since these systems would be integrated with each other, they would, and let me get it. First, it's state-based regional systems that are doing this. I think Kathleen brought that up, but they're no longer competitive. So they can help each other, for example, in disasters. If there's tornadoes 20 miles away, we can mobilize regional healthcare resources in to help there. The regional systems are governed by a council of interdisciplinary providers. And this was the big administrative change I thought had to happen. Because as it stands now, the system goals and the provider goals are asynchronous. And we have to restore that system design to the goals of medicine and nursing and the other healthcare professionals, most of whom have codes of ethics like we do. And the other advantage of this was that it also included academia, public health, EMS at these tables that decide key issues, for example, distribution of resources, community needs, and then what we can work together to come in to deliver those services to the communities. If you go down the goals, it kind of outlines the evolution of this model.
And John, I'm just going to cue you that 15 is up. If you can wrap up, I hate to leave it hanging, but we'll give you 1 more minute.
Sure. No, thank you very much.
Sorry.
So the goals are kind of the key. Each one is kind of a little silo. For example, I had to design or come up with a new community assessment tool because I didn't feel the public health ones I looked at were very thorough. And since 90% or more of what we think of as healthcare is actually nursing care that people need, it made sense to use a nursing-based community assessment tool. Well, I'll let you have the goals there. I guess, sorry, my time's up.
John, you know what I love, and from all 3 of you, is there's such passion for this work that you're doing, what you've created, what you're doing, and the rationale behind it. So I thank you so much, and I think you both have teased enough that people will reach out and ask for more. So the emails, your LinkedIn URLs, those were added, and I anticipate that you're going to get some outreach. I hate to cut you off, John, but I do want to open it up for some Q&A. So allowing others who have joined us today to ask further questions. Gabe, I see your hands up.
Yeah, so I'm not turning on my camera because my face is still partly full of food, but John, really great to finally meet you a little bit virtually. And I caught the end of the conversation, but the thing that really struck a chord for me is this question of is healthcare a right or a privilege, and what do we do with that? And I think this is one of the places this conversation about transformation gets stuck, is because people can't necessarily agree, or not even enough of us are talking about that. But I've started to wonder if we should expand the question into things like, you brought up basic infrastructure like electricity, and like having conversations about how is this more of an infrastructure problem, and how can we make it clear that it affects everyone when we don't have adequate care for so many people, that it's not about like whether it's a right for me, Gabe, to have medical care, but it's as a society that I'm part of, I suffer as a member of the society if other people don't have care. And so, I mean, it's a personal interest for all of us, aside from a societal and community interest, that it should be. So, like, rather than speaking to people about philosophy of whether it's a right or not, let's just talk pure, like, nuts and bolts of how society works. And I also have been exploring, is it an issue of national security? I mean, what kind of language will get people to take action, right? All right, that's all I got.
Love it.
You're absolutely. It's also a productivity issue in this country. So, and not just to mention the consequences to individual lives and to the despair in communities with so much comorbidities that we see now, and then the inability to access, real advice from healthcare professionals, and not just what pops up on the internet.
I'd like to talk about the national security issue. The Pentagon did a report, over 77% of applicants for the military in all branches needed waivers, medical waivers. So yes, it's a matter of security too.
After 9/11, for example, over 65% of the people that tried to join the military were rejected for military or for medical.
Yeah, and then 77% needed waivers. Yeah.
Roberta, I see your hand up.
Sure, thank you. I am part of NTH, and I think, John, if you could just give the example that you've given before about how it would be paid for as a public utility. You give the example about the kid who breaks his arm and they get the bill in the mail, and I think that would be instructive to everybody, just to get a better understanding of how this model really works on the ground.
Sure. Well, with the direct experience in the political system, I realized pretty quickly that, with all the money coming in, it can vary from 100 million to 300 million a year coming in from the specialty groups in healthcare, that really the only way to go forward for us was to develop a public media campaign to educate people that there's another alternative. So I designed a series of commercials, and that's where we are at NTH now, is trying to get the funding to get these commercials produced and then put them into some markets around the country. So the commercial she's talking about it's a real easy commercial to do. A man walks out of his house, he's looking at his mail. There's a scream inside, a voice scream. She broke her leg. You see an ambulance, and they're going to the hospital, and they're walking back in their house. And the wife says, how much did that cost us? We're a little short this month. And he talks about the copay and the deductible. And she looks at him and goes, honey, we really can't afford that this month. And then the flip side of that commercial is the exact same scene, exact same thing up until they're walking back to the house. And she goes, how much did that cost us, honey? We're a little short this month. And he looks down at his utility bill, sees healthcare $50, and he goes, it didn't cost us anything. And I think that's the message we're trying to bring out, is we can easily afford healthcare in this country without having to bill everybody for insurance. So we get rid of the insurance burden on physicians, so they don't have to worry about pre-authorizations. The downside is that you need a very invigorated peer review process for all of us. Thanks for the question.
Yeah, there's a question in the chat from Marlene Seiden asking, can you please describe the current model being tested?
Is in the Spicewood project? Yes, we wanted to see, we knew that looking at the social determinants of health made a difference according to the research, but we wanted to see what a nurse-led model with a holistic picture of each patient would look like. For example, a woman just came in yesterday, and all she wanted was money for rent. And what we found out, she hadn't paid her Medicare premium. She didn't have any insurance yet. She had chronic illness. So, we do a holistic picture and realize the most important thing is for her to get to the doctor. And she didn't know she qualified for, the no Medicare, and we address her needs. And it's just wonderful seeing that now she's going to go to the doctor, and, we're going to prevent that chronic disease from going down. We prevent hospital readmissions. We've saved 2 lives. And that's just in our program that's not even been a year old. So, what we learned, and this is what I want to throw out to you and ask for your help with, is that after we look at the money spent, and after for the nurse and the nurse practitioner, and we look at all the outcomes, all the Z codes that have been captured, all the Z codes that have been resolved, all the money that has been captured for these people, instead of the church just handing out, they had a ton of resources that they were entitled to that as we know in the country, the resources aren't getting to the right people. So that did that as well. but they're on the Excel spreadsheet. When you look at it, there is no column. If you're going to change healthcare from a business to a service, you need more columns on your spreadsheet. Where's the column for the connection and the relationship that the patient has with their primary care provider? Where's the column for genuine caring that motivates another person because you care about them to care about themselves? Where's the column for increased connection? Because we know that there's social, disconnection, and only 16% of Americans feel connected to their communities. So as you create a new movement, or as we switch this to a service, we need different measures. What do you want to measure? The quality of life index is a good one that is being used. But do we ask that question? Are you happy? Do you actually perceive that your caregiver cares about you? Do you feel cared for? These are important questions when you create a model that is based on service.
I want to clarify one thing. This is not a competition between nursing and medicine. We need everybody working as partners together to address these needs in a very complex geography. I mean, if people often want to compare the model in Germany to the model in the US. Germany's smaller than the state of Montana. We share much more in common with countries like Canada and Australia, and they are struggling with the single payer. We do have an advantage in this country in that we have an army that's not being fully utilized, and that is the 370,000 nurse practitioners that are out there. So we have an advantage other countries do not have to get out and, again, work in partnership with medicine, with pharmacy, with nutritionists, with physical therapists to really bring health into the communities. And then understanding that community health is not just how many diseases are there and how many hospitalizations we can reduce. A healthy community has a sense of optimism, of progress, of being engaged in the community at large. And while healthcare can't solve anything, everything by itself, having some kind of resource in a community allows you to bring in other state resources, for example, that can augment the health of the communities.
And also, we're doing some research at the University of New Hampshire. The students, Emily Spensky at the University of New Hampshire, is doing a needs assessment with their students, trialing the assessment in a community, and going back to the community. So a nurse does a care plan for a patient. And I guess one of the things that we learned in Texas was that people don't know what nurses do. So that was interesting. They thought that we were glorified community health workers, but more expensive. I think that was one of the comments. So not understanding the role of a nurse and how you do a holistic picture and how you do a care plan, that was important.
Keely, I see your hands up.
Thank you, Denise. I have to start by saying I love John, this whole concept. So if it sounds like I'm being trying to be a rabble rouser, I am, but not out of anything but love. My question is that when we look at smaller communities, in my mindset, where we have more of like a tax-based model to pay for healthcare, the taxes are, in line with your income. When we're talking about a utility, often people end up paying more for electricity in proportion to their income than a wealthier person would. How do you, see a solution for that to make it more equitable for people to access?
Sure. Well, again, I go back to the fact that we have no idea how much healthcare actually costs in this country. And there's multiple reasons for that, but if you've ever read, for example, Uwe Reinhardt's work, and you look at how pricing was developed in healthcare, they basically just made all this stuff up. So I'm thinking that, when I looked at my model and we did the economic analysis, we're showing a 42% reduction in healthcare costs in this country, which is a pretty big chunk of money. So we can make individual decisions about progressive up to a certain point, but we don't want to become a money pit. So one of the goals in this utility model I'm talking about is cost efficiency. And so part of that is these regional systems working under a budget. And then they can decide the innovative strategies that they need to reach particularly small communities, which is a very difficult challenge when they're 60, 80 miles away from, metro areas. But I think the solution to that really is nursing innovation. So Kathleen said a lot of people don't understand nursing. We've got over 140-year history of finding people in this country that need help and helping them. Whether it was tenement buildings or rural gullies in West Virginia or small desert communities in Arizona. So this kind of innovative delivery is inherent in nursing. And when you add in the fact that the reason I put nursing as the chair of the regional systems was that we have an ethical obligation and understand that healthcare is not just this patient in this bed, but it's also a broader picture of communities and states and national health. And again, we work as partners to do that. So yeah, there's going to have to be, other economists that come in and say, okay, so this is the budget. How do we arrange that with some kind of progressive level of payment? But whatever it'll be a lot less than everybody's paying now.
And none of us can do this alone. We're so excited to collaborate. That gives me more hope than anything. We need each and every person on this call and your wisdom and your expertise and your input, to make it happen. You believing that everyone has a right to be well. If we believe that and hold that up, and then as Todd was saying, the sacred, what a great word, Todd. The sacred relationship, reclaiming that sacred relationship between the physician and the patient, the nurse and the patient, reclaiming that is really the essence of any new system, because that relationship has been lost.
Leanne, I see your hands up. Please go ahead.
I was just going to say that not only does everybody have the right to be well, we cannot be a well society if we do not have the vast majority of us being well, because those people who are not being treated will be sick. They will spread whatever sickness that they have. So the idea that we don't want to give something like this away, the idea is we need it for everyone to be healthy. We have to have, people taking care of themselves and being taken care of in ways that move us forward to a healthier country. Right now, we're sitting ducks.